Welcome everyone. My name is Brad Chickwin, and today I'm going to cover anatomy and electrophysiology of the ticker, also known as the heart. This is one of a three-part series of cardiac training that I offer. Subsequent programs include an EKG 101 class, which simplifies a basic EKG rhythm for all license levels, and then a 12-lead and STEMI recognition program to which helps guide you on the correct way to activate the cath lab. I have no disclosures. Objectives of this program is by the end of the presentation, you'll be able to describe the gross anatomy of the heart and understand the basic electrical conduction within the heart itself, which leads us to our EKG rhythms. The reason why I offer this program is before we understand and learn about the EKG, we need to understand the basic pathophysiology of the heart. So let's dive in and discuss our heart and the vessels inside of it. Our heart, locked and loaded. First and foremost, it consists of 4 chambers. It's the size of a fist. It pumps blood throughout our entire body. It conducts its own electricity. And 33% of our patients end up having heart-related issues. As it pertains to the pump, being our heart, an average person has 5 to 6 liters of blood. It pumps about 20 liters a minute on average. And in about 60 seconds, our heart can pump all the blood out of our system. The layers of our heart include the endocardium, the myocardium, and the pericardium. The endocardium is a small inner layer where blood touches the muscles. The myocardium is the biggest and thickest part of the heart, so this is where the MI evolves. Then the pericardium, which is the outer layer, which has a pericardial sac to which has parietal fluid in it. As it pertains to the heart valves, we have atrioventricular and semiluminar. The atrioventricular, also known as the AV valves, separates the atria and the ventricles. This is your tricuspid valve and your mitral valve. And the semiluminar valves, also known as SV, these are the valves that prevent backflow. There's one-way movement through them. You have the aortic valve, which is the blood to the heart, and you have the pulmonary valve, which is blood to the lungs. An easy way for you to remember the order to which you have the valves of your heart is toilet paper, my A asterisk. So you have the tricuspid valve, pulmonary valve, mitral valve, and aortic valve. Some fun facts about the heart. Pulmonary arteries carry deoxygenated blood. Pulmonary veins carry oxygenated blood. The right side of the heart is the low pressure side of the heart. And the coordinated tendoning is the supporting cartilage that maintains the shape of the heart. Let's trace a drop of blood through the heart itself. Deoxygenated blood enters the right atrium via the inferior superior vena cava. The right atrial wall contracts, forcing blood through the tricuspid valve. Blood now sits in the right ventricle. The right ventricle contracts, forcing blood through the pulmonary valve into the pulmonary arteries. The pulmonary arteries carry the deoxygenated blood through the lungs. The oxygenated blood is carried out of the lungs by the pulmonary veins to the left atrium. The left atrial wall contracts, forcing blood through the mitral valve. The blood now sits in the left ventricle. The left ventricle contracts, forcing blood through the aortic valve. The blood is now in the aorta and pumped to the rest of the body. Remember, this happens in a blink of an eye. So let's dive into our coronary arteries. The left coronary arteries feed the atrium and the left ventricle. When this artery becomes clogged, an MI evolves, and it's sometimes called the widowmaker. It's quite lethal. Right coronary arteries feed the right atrium and the right ventricle. It directly affects the AV node because in about 90% of people, the RCA directly supplies blood to the AV node via the AV nodal artery. This diagram is an excellent depiction of when blood ceases and how distal damage occurs in the coronary artery when there's an infarct. These are all different types of infarcts that can occur within the coronary arteries, and you can see that every infarct distal to that is where the tissue dies. So let's look on how blood goes from the heart to the body through our vascularity. So let's do a quick review of the peripheral circulation. We have the arterial system and the venous system. The arterial system, it's high pressure. It takes oxygenated blood away from the heart. The tuna medica, the middle layer, is thicker than the venous system. In the venous system, it's low pressure. Deoxygenated blood is carried to the heart, and the tunica media is thinner than the arterial system. So let's go into the cardiac cycle involving the systolic and diastolic pressures. When it comes to our blood pressures, you have a systolic and a diastolic number. The systolic, which is the top number, is the heart contracting during afterload. The diastolic number is the number on the bottom when the heart's at rest during the preload phase. We also have to worry about cardiac contractility, which is the strength of each heartbeat, or the squeeze, because it helps determine the volume to be pumped. Remember, cardiac output is stroke volume times heart rate. Let's look at some cardiac physiology terminology. Automaticity, pacemaker cells' capability to self-polarize. Conductivity, the ability of the cells to receive impulse from another cell. Excitability, ability of the cells to respond to electrical impulse. Contractibility, the ability of cells to contract or shorten. There's also three terms to remember: chronotropy, which is heart rate; inotropy, which is the strength of cardiac muscle contraction; and dromotropy, which is a rate of nerve impulse conduction. Electrophysiology of the heart. Fun fact, only the heart has intercalated discs that connect muscle fibers together to conduct electrical impulse. The dreaded sodium-potassium pump. Let's simplify it by going over the main electrolytes. You have sodium, potassium, and calcium. Sodium is a myocardial depolarizer. It slows and stops the heart from firing. Potassium is a myocardial repolarizer. Too little will not recharge the heart properly. And calcium is a myocardial depolarizer and contractor. It slows and stops the heart from firing. It's all about the myocytes. Myocytes are specialized cells that contract like muscle, but they also react to the transfer of electrical activity like nerve cells do. When a myocyte is at rest, it is called polarized, and the inside of the cell is negatively charged. When the myocell becomes depolarized, the interior of the cell becomes positively charged and the cell contracts. Polarization, depolarization, and why do we care? Think about the potential energy in a slingshot. The band can either be at rest or it can be pulled back, made really tight with a slingshot just waiting to be released so it can snap back. Polarizing the cell is just like stretching the band out, leaving it primed and ready to contract. As soon as you release the slingshot band, it contracts and snaps back into place, transferring all of that energy and doing work. Polarization, depolarization, and how does it happen? There are 5 phases that occur almost instantaneously with the cardiac muscle. Phase 0. The muscle is stimulated when there is a rapid influx of positively charged sodium ions that move into the cell. Phase 1. With the influx of sodium into the cell, it causes potassium to move out with that positive charge, and then the charges become balanced. Phase 2. Sodium stops moving into the cell, calcium starts moving in, some of the potassium moves out, then the muscle contracts. Phase 3. The calcium stops moving in, the potassium gets pumped out, and the cell becomes repolarized. Phase 4. The cell is at rest and is ready to be depolarized, so here's your diastolic period. What does this all have to do with an ECG? There is movement of an electrical charge when the heart is contracting. So let's put a battery tester on our heart. Limb leads 1, 2, and 3. Hopefully you've seen this photo before. That's on the right-hand part of your presentation. This is called the Einthoven's triangle. The limb leads are a way of conducting voltmeters to the heart. Each lead looks at a slightly different angle of electrical activity, measuring a slightly different vector of electrical force. The electrical force moves with magnitude, direction, and polarity. This creates an electrical vector, which the leads record. This force creates a moving electrical vector. A positive charge facing a positive lead causes an upstroke, and a negative charge facing a positive lead causes a downstroke. So this creates an EKG or an ECG tracing. A positive charge moves towards a positive lead. A positive charge moves away from a positive lead. And a positive charge not moving towards either one of the leads. And hand in hand with the electrical impulse that we just went over, the cardiac conductive system has a predetermined route for each cardiac beat. The SA node, the heart's pacemaker, fires at 60 to 100 beats a minute. This firing travels down the internodal pathway, which runs through the right atrium and sends a signal all at once through the atrium. The AV node receives a signal from the SA node instantly and holds that signal for a second or two before sending it into the ventricles. It can also operate by firing 40 to 60 beats a minute if the SA node fails. The bundle of His sends that energy to the right and left ventricles to the bottom of the ventricles. The Purkinje fibers branch off from the right and left bundle branches so that the ventricles get the cycle at the same time, and the Purkinje system takes those signals within the ventricles and causes the heart to contract and move blood to the rest of the body. It can operate by firing 20 to 40 beats a minute if both the SA node and AV nodes fail. This is where your heart blocks come from. So to take what was just explained and put it into a visual diagram, here's a picture of the heart cut in half. What I want to draw your attention to is the location of the SA node, to the AV node, to the Purkinje fibers that run all along the outside of the heart on the bottom there. Remember, the SA node can fire 60 to 100 times. The AV node is 40 to 60, and the Purkinje fibers can fire 20 to 40. So putting it all together, you get your EKG rhythm. Fun fact, If there are no ups and downs in your life, it means you're dead. Those are the resources I used to put together today's presentation. As always, thank you very much for watching my presentation. I hope you took something away from it. Please reach out to the email listed on this slide if you have any questions or comments. Thanks again and have a great day.